Welcome everyone. Let me introduce my PhD thesis title, which is Artificial Intelligence in Oral Medicine. I'm Dániel Horváth. I'm a prosthodontist at Semmelweis University Department of Oral Diagnostics, and my vision is to provide an artificial intelligence-based guide for clinicians, which can help to diagnose and treat oral medicine patients. And my vision is to verify artificial intelligence as a reliable support for clinicians find the possibilities and the limitations of this technique. Right now, to achieve my goals, I have two specific ongoing projects, which led me to use the first one, which is investigation of the diagnostic accuracy of artificial intelligence in oral potentially malignant disorders, and want to achieve it with the methodology of systematic review and meta-analysis. Oral cancer is an urgent problem nowadays because almost 400,000 new cases every year and almost 200,000 deaths. This is the sixth most common cancer, and in Hungary the situation is way worse because we are the third in incidence. The 5-year survival rate is pretty low. It's about 40% because we diagnose these lesions in later stages, in stage 3 and 4. But if we can diagnose these lesions earlier, the 5-year survival rate can jump up to 80%. But what's before oral cancer? We need to know that oral potentially malignant disorders only have is a very diverse group, but there is only one common property, which is all of them can develop the oral cancer. The worldwide prevalence is below 5%, and right now it's an experience-based diagnosis, and we are humans, we make errors, and the diagnostic errors can lead to the death of the patient. So with an earlier diagnosis, we are able to save thousands of lives. So our aim is to investigate the diagnostic accuracy of artificial intelligence in oral potentially malignant disorders. That leads to our clinical question, which is, what is the diagnostic performance of artificial intelligence in oral potentially malignant disorders? We use the PERT framework, and we hypothesize that artificial intelligence can diagnose oral potentially malignant disorders with the same accuracy as histology can. Here you're able to see our search key, and we use this search key in 5 main databases, and we ended up with almost 12,000 records. Unfortunately, at the end of the flowchart, we ended up with 6 eligible articles. The outcomes were the diagnostic measurements like sensitivity, specificity, positive predictive and negative predictive value, and positive and negative likelihood ratio. All the outcomes are analyzed. And let me introduce the first one, the sensitivity and specificity. We need to know that all of our studies investigating more than one type of architecture, and that's why we have to, because the overlapping population, we have to choose which we're going to use, and we've suggested to use the data from the highest sensitivity ones. So here we're able to see the sensitivity and the specificity values with the 95% confidence intervals, and we can see that the overall sensitivity is 0.93, and the specificity, the overall specificity is 0.94. But we have to make it into context, so we have to compare it with someone. So we have to compare it with the general practitioners and also the experts. And if we compare those, we can say that if we compare the sensitivity of the AI with the general practitioner sensitivity, we can say it's a significant difference mathematically and also clinically. And if we see the sensitivity of the experts is also significantly lower than the sensitivity of the AI. When we investigating the specificity, we can say none of those groups reach the mathematically significant level yet, but if we see the general practitioner specificity, we can say it's clinically relevant difference. If we go further to the predictive values and likelihood ratios, we can see that the predictive value by study level are pretty high also in the positive and negative predictive values. But if we see the overall one in the last row, we can say that the positive predictive value is low. That's because we calculated the predictive values on study level and with the prevalence within the study, but the overall predictive values were calculated with the worldwide prevalence. And if we go to the likelihood ratio, we can see that the positive likelihood ratio is above 10, so it's 20.77. It's considered to be pretty good. And the negative likelihood ratio is below 0.1, so it's also considered to be good. About the strengths and limitations of our study, we can say that all of our pictures was biopsy proven. We work with huge amount of pictures in most of the studies. We have well-described architectures, and also we know everything about the teaching settings. About the limitations, unfortunately, we work with low number of studies. Different amount of teaching pictures was used within the study, and same teaching settings was used within the study for all the AIs, which can lead to discrepancies. So our conclusion is that artificial intelligence can diagnose oral potentially malignant disorders in intraoral photos with exceptionally high negative predictive value and low positive predictive value, which leads us to the implication for practice that it's a good non-invasive tool for screening. That means that if someone came to our office or where is lack of experts, they have to make a picture of the lesion, give it to the AI, and if the result is negative, then they don't have to refer it to the expert, but if the reason is positive, then it's for sure the patient needs to find an expert. And at the end of the day, that's going to cause less burden on the special care. On the implication for research, we have to make a globally available labeled oral potentially malignant disorder pictures database to develop new architectures, and we also have to develop better multi-class classification models. So we finished the manuscript writing. We are after the language editing, and right now we're going to send our manuscript to the plagiarism check. And our target journal is Journal of Dental Research. And let me introduce my second project, which is a prognostic evaluation of diagnostic criteria in oral lichen planus on histological images by artificial intelligence, and it's going to be registry analysis. So oral lichen planus is the most common oral potentially malignant disorders. If someone has this disease, it's always decreases in quality of life, but there are several symptoms on it, but we need to know that all of these lesions are treatable with the adequate therapy. Right now, there are many different diagnostic criteria, but we don't really know what are the prognostic values of them. So right now, we have a significant volume of unprocessed data in this topic, and we know that artificial intelligence are able to manage big data. That's why our aim is to investigate the prognostic values of diagnostic criteria in oral lichen planus with artificial intelligence. That leads to our clinical questions, which is what is the prognostic value of different diagnostic criteria in oral lichen planus. We're going to use the PFO framework with the F when we see the characteristics that are able to investigate on the histological side, and we hypothesize that Schwivat bodies and lymphocytes in the epithelium have higher prognostic value in oral lichen planus, and it's going to be, the implication is going to be more accurate diagnosis. So right now we have two ongoing projects, both related to oral potentially malignant disorders and artificial intelligence. And let me thank your attention with a quote from Albert Einstein: "Try to not become a man of success, but rather become a man of values."
Thank you. I wanted to ask earlier as well that when we are talking about the teaching of the AI, what would be the data point is necessary? That is, well, how many pictures are necessary to have an accurate, relatively accurate diagnosis like this?
So it's pretty hard because it's pretty dependent of the complexity of the pictures. In this case, almost all studies work with more than 1,000, so between 1,000 and 2,000, or there was one study which worked with 3,000 pictures in the teaching settings. So pretty huge amount of pictures we have to we need to have, but it's pretty differs between studies because of the complexity of the pictures.
You mentioned that you will make a registry analysis, and I am just curious that do you have your own registry or what?
So right now we are making this registry. We do some preliminary investigation. We have retrospectively about 350 histological slides, but we need to re-evaluate all of them through to new criteria to contain all those that I showed of the characteristics.
My question is regarding, well, not your projects, but the whole process of detecting these lesions as soon as possible. So to speed up the whole process, it would be evident that maybe the AI should help us evaluating the histological samples of these lesions. Do you know anything how accurate they are on these samples?
So if we are talking about the
histological analysis of these.
I already found 2 articles that's investigating the diagnostic accuracy of artificial intelligence on histological images in this. So if we talk about oropotentially malignant disorders, they are pretty good, but we have to say that to diagnose those lesions, we also need the clinical features, not only the histological features. So basically, we need to know the clinical appearance and the histological appearance, and if they correlate, we can say that the patient has that sort of lesion. So that's why it's pretty hard to tell what is the exact numbers if we only investigating histological slides.
You mentioned that the overall specificity or success rate was based on the worldwide prevalence, and I didn't understand that. Why did you use for statistics in a external value or whatever? I'm afraid I won't answer your answer as well, but try me.
Okay. So basically, within a study, there was a big difference in prevalence. Most of the studies were used high. So if we had 1,000 pictures, 500 pictures was OPMD pictures and 500 was benign or healthy mucosa. So the prevalence in this case was 0.5. But overall prevalence is below 5%. So the statisticians suggested to not use and do not calculate the prevalence of the studies, so the overall prevalence of the studies, but rather use the worldwide prevalence, which maybe not the best choice, but we can manage it like this, because in our practice, usually the prevalence is way higher than the worldwide prevalence, because we meet patients with some kind of oral lesion, and it's going to, so in our case, I think if we would use this kind of artificial intelligence in our practice, the positive predictive value going to be way higher than I showed on the slides.
I understand the whole topics, but I'm not sure that the statistics is right. Because I think this will be causing false negative, increasing the false negative prediction rate. I'm not sure. And for a disease, we want to have more positive. False positive is better, because then you make other diagnoses and so on. So I'm not sure. I understand now, because in the training training test of machine learning, this is common that if you have too much value from for example, control. For example, rare disease is the same example, and then they try to change the thresholds, but I'm not sure that this is the right way. And it looks very strange that you have studies with high sensitivity and then you have this overall.
Yeah,
so
true.
I'm a bit of over discuss again. So.
Okay, thanks.
If I may ask, like as you said, like you can take a picture and send it to the AI. Like, is it a simple picture with mobile phone and camera, or it requires special light and ring flash and?
So basically, in these studies, that was a LGBT criteria that don't use any kind of special equipment. So only just regular digital cameras was used on mobile phones. So that's why no special equipment is needed. But we need to. So the program have to give you some feedback about the quality of the pictures, because if it works with bad quality pictures, the results going to be less reliable.